Welcome to this panel. I'm David Muehlstein. I'm the Chief Strategy and Chief Research Officer at Levitt Partners, a consulting firm that does a lot of work in value-based care and understanding how payment reform is driving delivery reform and how it's playing out in different markets across the country. We've got a great panel today that I'm excited to let them talk to you about their experiences and answer some questions around what really needs to happen for ACOs to continue to be successful. So I'm joined by David Klabonis, who's the Chief Operating Officer at the Palm Beach Accountable Care Organization, by Gail Pierce, who's the Chief Population Health Officer at Millennium ACO, and Travis Broom, who is the Senior Vice President for Policy and Economics at Aledade. We're going to start by having each of them give a little overview of their ACO and talk about some of the experiences that they've had to date, as well as what the ACO looks like. And then we're going to get into some very interesting questions around what is necessary for success and what changes need to happen going forward, and what their opportunities are for continued success for what they're doing. So we're going to start with David. So I'll turn it over to you, David.
Great. So hey, I'm David Klabonis, Palm Beach ACO. We're a 100% physician-owned and operated ACO in South Florida. We started in 2012, and yes, I was with the company back then. It's pretty funny to say that, you know, we've now been in the ACO business for 8.5 years. We have 400 PCPs, 300 specialists, and our independent practitioners have worked really hard in the program. Fortunately, been able to save a total of $471 million, in which we've distributed, so actual payments to physicians, $194 million. So our doctors have worked hard, and the program has been very good to them. You know, one kind of point is most of our practitioners are 1 to 2 physician groups. So we have 350 TINs in our ACO. So a very broad model, which is probably going to differ a little bit from some of the other folks in the call. Thank you, David.
Gail?
Good morning, everyone. I'm Gail Pierce, and our model does differ quite a bit from David's. Millennium is a single TIN. We have over 500 physicians in 19 counties throughout the state of Florida. We are also on one EMR. We started in the MSSP model in 2013 with 29,000 beneficiaries, and last year we were in the enhanced model with 70,000 beneficiaries. Our model has also been successful, although I think we try to balance the shared savings initiatives with just the day-to-day operations of the physician practice. So.
Thank you, Gail. Travis?
Hi, I'm Travis Broom from Aledade. We have had our ACO in Florida since 2016, so it's a little younger than these guys here in Florida. Been physician-owned practices, mainly across the central part of the state, yes, including a little bit in the villages and all that brings to the fun. The Aledade as a whole, many of you know, supports independent primary care practices and community health centers across the whole country. We have about 5,600 providers and about 800 practices in 31 states, spread across 38 different ACOs. Like I said, our ACO in Florida is part of what we call our 2016 cohort, and that cohort is 5 ACOs that have really kind of proven out some of the things, you know, David and things was talking about. The over time, it really matters, and we're going to talk a lot more today, I think, about how that over time and sticking with it really pays off. Because at the end of the day, the coolest stat for me when you talk about performance of the ACOs is in Florida, the practices, almost 40% of their Medicare revenue now comes from shared savings payments. Might even be higher from David, but no more of this like 5% AAPM bonus stuff. We're finally talking about real revenue.
Well, let's actually start right with that with you, Travis, and talk a little bit about what you've seen happen over the time that you're the Aledade ACOs in Florida, what you focused on initially and what you're focusing on today, and also give a little bit of context of what you've seen across all of Aledade to get that national perspective.
Yeah, certainly. I think, and really in Florida, it's been surprisingly consistent across the state or across the country in what works. I think Florida, the physicians are just really primed based on their past experiences to be early leaders. Like I said, I'm the young guy on this panel from an ACO years here. But as far as the work itself, it seems to work in Florida, in Louisiana, in West Virginia, in New York, in Utah, et cetera. And really, the kind of two big learnings we learned over time that really drive the savings. One is that the tools don't always work the way you think they do, and you need to really make sure you have understanding of what is a given tool accomplishing. So annual wellness visits was a great example from us. If we were talking in 2016, I would tell you the story that I would have given anybody in 2016 about our doctor who got the patient in, finally convinced them to do an AWV after multiple outreach calls. They come in, the doctor creates that personal touch. They allow them to convince them to get a colonoscopy. They find a polyp, they catch it early. Colon cancer avoided. That's a great story. The number needed to treat for that is really, really high. It is a great value creation story. It's not particularly high savings creation story. What we found over time is that we really make savings up to, and we published on this, up to about $500 per patient per year on not the patients who AWV is the only thing they come into the office for and you do prevention. We make our money on AWVs for patients who will be in the office 6 other times that year. Those high risk, high chronic patients, because the annual wellness visit really is almost the annual step back, almost like an annual strategy meeting. You know, it's almost like an annual health strategy meeting with the doctor. And so that's been a big area of change as we've gone forward. The other piece as we've matured is really pushing the envelope when we talk about like, what is performance, right? We used to be like, oh, 50% AWVs, that's pretty good. The benchmark now is 80%. And of those high priority AWVs, trying to hit 100. It's like, oh, if I catch half the patients coming out of the hospital for a TCM, that used to be really good. But when the ACOs are really high performing, really making a lot of savings, you're talking about, we're catching everybody coming out of the hospital. So really pushing understanding the basics and then really pushing them to really high levels of performance.
Well, David, talk a little bit about your experience with your single ACO, how you've seen similar things, but also seen other or had different focus areas that have evolved over time. And you're muted.
It's been an education for me personally, is just recognition this is a multi-year project. And I'm excited what we're going to learn after 10 years. But you know, absolutely what Travis said we found to be true is, you know, the first couple of years you work on, you know, panel management, which includes the annual wellness visit. It includes TCM to make sure your patients are managed. But, you know, that is not where the significant cost savings comes from. And, you know, this one conversation happens all the time. I do everything the ACO asks. I do my wellness visits. I do TCM, but I'm not saving. Right. And we have to get a lot more granular on, you know, how they are managing their high risk patients and actually how they are truly treating patients and dropping that PMPM. That's another thing is, you know, the physicians get disconnected of how the payment model works. Often they believe that they're a great physician, you know, based on subjective information. They don't pay close attention to the objective information in the PMPM. And, you know, we still have physicians that are very surprised by their payments because, you know, we have to continue to work. And like I said, it's a multi-year project, is to drive them that their actions around care management and their interventions to prevent ER visits or their interventions to manage post-acute, that's really what drives the PMPM and their payment. But boy, it takes multiple years of excitement about their annual payment and disappointment about their annual payment for them to really grasp those concepts.
So keeping the physician's eyes on the ball. So talk about some practical ways that you've done that. And you mentioned it takes a long time, but what are some interventions or things that you've done to really help them know what's important and disregard the things that's irrelevant?
You know, the other folks in this call do this really well, but you really have to pay attention to point of care. The opposite would be is you have this great meeting where you provide education. The doctors come in and they say, that's great information. And then they go back to their practice and they do the exact same thing. So, you know, what we've learned as, you know, a mature ACO is you really have to drive interventions in the office. So you have to make sure that they're consistently bringing their ER frequent flyers and tracking it. You have to make sure that they're bringing their drop patients in and tracking it. And we've really kind of migrated away from general education. We've migrated away from paper reports that aren't really measurable to using tools that measure point of care interventions so that we have a lot more detail of who's doing the work and who isn't. And I tell you, it's night and day on how the work correlates to the payment. So the doctors that get it done in their office point of care, they have great results and they're not surprised. And the ones that don't, they don't.
Well, Gail, talk a little bit about your experience. So you've got a very different environment. It's not a bunch of independent physicians. It's a single group that's spread out. How have you been able to be successful, and what have you done to drive some of the changes and the continued improvement that you've been able to see?
I think the one thing that we've learned is that the value-based world has to support the physician's office. We use the term making the hallways easier or being an extension of the physician's office. So exactly what David said, when the patient is with the physician, we have a unique time period that we can close gaps, increase HCCs, have that meaningful relationship so that they will want to take care of themselves. And so what we try to do is maximize the value of that visit for the patient, and then try to support the physician through different technological things or support like social workers or things like that. So for us, it's every year we try to identify easier ways to make, or better ways to make it easier for the physician to do all the things we're trying to ask him to do, from the value-based world to just basically getting those RVUs for the payments from CMS.
So, Gail, one of the important parts of working with physicians is getting feedback. So how do you get this feedback to know what they need and how you can make their lives easily? How does it work in practice?
First of all, it's really important to us. And so even though we have all these different offices, over 100 different offices, most of them do different things. So the support group, we have to be very flexible and do different things because of the way they want to treat their patients. So they have direct line access to everyone in the quality area, case management, in terms of coding and everything like that. But the biggest way that we get the feedback is we have a great group of physician leaders called our Physician Executive Committee. So before we implement any programs, those physicians critique our committee and support us in the implementation. Then we have monthly meetings that we call pod meetings that we have feedback as well. So it's if you can have a great idea, but if you don't implement it well, it's not going to go anywhere. So that feedback is really important to our success.
So over the years that you've been doing this, how have things evolved in terms of the services that you're providing to the physicians, the feedback that you're getting? How is it different from when you started, 7 or 8 years ago?
I think one thing is we've got to be flexible with different areas. So the folks in Southwest Florida do things a lot differently than the folks in Jacksonville. Every single hospital does things differently. So we have to readjust our workflows, like, for example, post-acute care processes. The post-acute care process that works in Jacksonville does not work in Naples. So we have to be very flexible, listening to what they have to say so that the physicians get what they need in order to truly coordinate the care of the patient.
So this is that challenge of identifying best practices, but having to implement them in significantly, dramatically different ways in different offices and locations. So you still get the outcomes you want, even though you're doing it in a different way. Right. I know in early years, it was a lot about standardization, but now you're saying it's standardizing maybe the outcomes or the intervention itself, but being very flexible in how that's being done.
Yeah, all healthcare really is local. Every hospital has a different EMR. And so we have to adjust our processes for that. But also all physicians are, they have they take great pride in who they refer to. They take great pride in really wanting to coordinate that care. So we have to support them in order to do what they think is best for the patient versus us telling, oh, this is a great idea, go do it. We have to adjust.
So David, you've got a smaller geographic area that you cover. Do you see a similar challenge with different hospitals that the patients work or physicians work with, or different office locations where you've got to customize things for their individual needs?
Absolutely. You can't be 100% standardized. So the approach that we've done is we have a menu, and there's always like, 3 options on the menu that are very consistent around panel management, quality, disease management, basically hitting the quality measures. But then you have several options that are typically data driven. So, maybe the practice has an issue with ER in that particular area. Maybe they have dual enrolled patients that go to the ER first. You maybe have a practice that has, very high post-acute costs. So our team of consultants will have their general approach, and then they'll have their practice-specific approach that they mix in. So, 3 items general, 2 items custom, and it's always data-driven. And we highlight the big issues, maybe home health or inpatient rehab is an issue. So each practice will get their custom areas of improvement.
So, David, you don't have one EMR. All your physicians aren't working on a single tech platform. So what do you do to make sure that you're getting the right information you need? How do you share information across providers as applicable? How do you grapple with that challenge?
Well, we really look up to Gale and the fact that they have a single EMR. We think that's a huge benefit, but, we've been able to effectively work around it. So, number one, the ACO has pretty extraordinary data rights, and you can get a lot of information into our central hub. So we have the Florida HIE, we have patient ping, we have LabCorp, Quest, Florida Shots, and that actually provides a pretty good repository along with the claims that we have potentially 70% of the information without hundreds of points of failures with the EMR integration. So, we're able to have a pretty good picture of the practices without the full solution. And then, we're able to have a small team of professionals that goes out and helps with the optimization of the EMRs. They found that to be an enormous benefit. Sort of what Gail had mentioned, our role is to help the practices. At times they can have trouble with the admin side. So we have a small team, and then they make sure that all of the documentation that the physician does, matches and interfaces with the ACO systems efficiently.
One of the challenges that ACOs talk about sometimes is that they don't have ready access to the data that they want to measure. So they either do one of 2 things. One is they figure out how to collect that. The other is that they say, well, we're just going to make do with these proxy measures because we have, we've got all the pharmacy data, for example, so we're going to use that as a proxy. What's been your approach?
We do a little bit of both. So, there's a lot of broken things in healthcare. So, if you have general information, especially here in South Florida, there's plenty of things that you can improve. So we definitely capitalized on you use what you have, and we used what was available in low cost. I mean, we could have spent a couple $1 million to integrate all the EMRs, and we wouldn't have gotten started right away. But what we did is we used the tools that were available to us, and we're definitely enhancing. So. Thank you, Travis, for bringing to our attention the BCDA. Medicare is doing a great job. They're making claims data now available within about a week through the BCDA new program. And then we're also investing in technology in the office so that we have a tool called the Sidekick, which is similar, I know, to what Alliday has, but it basically sits on top of the EMR, and it's able to prompt them for interventions using ACO data, and also, sometimes get some quality information back to them. So to answer your question, we're definitely doing both, and both tactics are very important.
Talk a little bit about the VCDA and how you're using that, what it is, and how other ACOs could leverage that.
We think it's amazing that you can get claims within a week instead of a month. And, now that we've had to survive on, monthly claims data, it's just extremely eye-opening on, the level of intervention you can get with weekly data. So we're still validating it for accounting purposes. So we're not comfortable yet using it for PMPM and, shared savings calculations used for payments to physicians. But we're definitely able to use it for, ER interventions. We're definitely able to use it for annual wellness visit, TCM progress. Often our team will go to the office and we'll train them and we'll think that they get to work right away. And we find out a month later or 2 months later, they didn't do anything. So with the BCDA and the weekly data, we're able to understand these interventions right away and act.
Okay. Well, let's change topics a little bit, and I'm going to start with Travis here. And this is about COVID. So obviously, that's the elephant in the room with what's going on. Talk a little bit about what you're seeing with results and how COVID is impacting ACOs kind of nationally, and then we'll get into some local impacts. But what are you seeing with the results and from all the ACOs that Aledade works with?
Yeah. So nationally, first and foremost, I mean, the robustness of the Medicare shared savings model, particularly with the changes that have been made over the years, and the one that's certainly coming to light now, is our move away from national trend utilization to regional trend utilization. Nationally, we see that costs are down around 4% for the year. They were only down another 1.4 in Q3, which is a much more stable Q3 than I think I was worried about. Attribution's down too. Lots of beneficiaries out there staying home, not having that one visit, telehealth or otherwise. But behind that, you're seeing huge regional variation. In Florida, inflation's still technically up a little bit for 2020. And we have a community health center ACO in New York City. They're down 15%. You know what? Both of those ACOs are in savings. And the reason they're both in savings is because New York's compared to New York and Florida's compared to Florida. And that's, so it's been a really, really just amazing actually to see how robust the program has been compared to other models like fee for service. Some of our commercial contracts have prospective trend, right? Which is all the rage to have prospective trend. You know what those prospective trends did not anticipate? A massive global pandemic. So we've been really, really pleased with what we've been seeing kind of on the savings side. And then on the work side, I mean, the infrastructure, even, 2 out of 3 of us work with independent practices, but like having that ACO background, having that connection that doesn't necessarily, rely on having the same EMR, for example. We were just talking about EMRs, right? You can roll out quickly a telehealth platform that sits next to the EMR. Now, our docs who can do it through their EMR, and I guess, Gail, you probably, I'm curious if you do your telehealth now through your EMR, they love that because it's integration great. But like, if that's not an option to you, having the connection through the ACO, I mean, we rolled out telehealth, I think in like 3 weeks to over 500 practices, which would have been crazy. So, I mean, I think both the program has been amazingly robust from a financial standpoint, based largely on the changes that FLICOS and others have advocated for over the last few years. And then having that ACO, having that population health mentality and having real population health support has been awesome for the practices as well.
Gail, so COVID has raised a number of different challenges. Obviously, there's patients that get COVID that need to be treated, but there have been a lot of other things that your patients have been dealing with access to needed care, mental and behavioral health type things. Talk about some of the challenges that you've been grappling with and how you've been approaching them.
So I think first and foremost, CMS just kept changing, the CDC kept changing the best practices and the guidelines for COVID. And so we were very fortunate to have a group of physicians that just kept on top of that to be able to educate all the physicians. It was very confusing. I think there were like over 50 changes since March as to what's the best practice. So I think that's been good. But what we also did is we diverted all of our case managers to at least having one contact with the patients who had COVID. And at one point we had close to 1,000 patients who had been diagnosed with COVID. And what occurred is that they had so much, because there was so much unknown, there was so much fear. And in a lot of instances, what our care managers actually ended up doing were being social workers, again, as an extension of the physician's offices to help the patients be informed about what to do with COVID, how to segregate from themselves if they were infected, how to segregate from other family members. We had several situations, far too many to appreciate, that where one spouse died and then the funeral home would not permit the beneficiary to go see, and so our case managers ended up being advocates on behalf, just to let a wife be able to see her deceased husband. So it was very and continues to be a really behavioral health issue, not so much in terms of diagnosis, but I think the trauma of COVID and the impact that that's going to have on our patients and as well as on healthcare providers will all be something that we look at next year. And we really need to manage, having constantly being on the front line, afraid if you're going to take home the infection to your family, is just something that I don't know that we truly know how to manage. Everybody's being heroes, that's fabulous, but it's got to have an impact on them eventually.
So now that Florida is starting to go into another wave like most of the rest of the country, how will you do things differently this time around? Any changes, or do you think you'll follow largely the same approach?
Yeah, I think we'll continue with having our care managers reach out to any patient who wants our assistance. I think in the beginning, there were so many things unknown. I think we're in a better position now to communicate what the protocols are. So I think that'll be better. And I think also with telehealth, we've had over 160,000 visits with telehealth. So I think our patients are more comfortable with it. The office protocols, the workflows, changing that workflow, like Travis said, to have telehealth in three weeks and be able to change all the workflows in order to make that happen. I think we're a little bit more accustomed to that part.
What about getting patients that need to see specialists to specialists, or that need certain surgeries or the like when they're closing down access to elective procedures? How have you been managing that and preparing for next year when COVID is past and being able to get the people what they need?
So in a few of our counties, we have a pre-op process. And so that is probably the best way to do it. That way we can coordinate to make sure we have all the coordination that we need in terms of pre-visits and stuff. But the best way I think that we've been able to try to coordinate that is, quite frankly, our relationships with the hospital CEOs, and being able to, number one, know what their capacity really is in terms of the ICU and the ventilators, being able to really try to support them as patients show up in the ER, to be able to determine if there's perhaps something that we can do to support the hospital's volume. And then for the elective surgeries, there's some elective surgeries, and then there's some other types of elective surgeries, and there's some that are just so critical to people's health. So I think we're working with the hospitals to try to help prioritize the different levels of elective surgery.
Well, David, moving to you, talk a little bit about your experience with COVID, what you've seen, and then also talk a little bit about your specialists and how you've been managing them during this time, and what you've seen that works and what maybe hasn't worked as well.
I just feel so fortunate to be in an industry that has an opportunity to make a difference. COVID was just an enormous crisis, and to see our frontline PCPs experiencing that firsthand. We had 6 PCP offices close. We had, and often, 80% of the office refused to come into work, call in sick. And the PCPs were really, really struggling. And as soon as that happened, we felt an urgency, we felt a calling that we needed to support them. So we immediately started having, number one, building of infrastructure to make sure that they had tools to be able to manage their patients and candidly to keep their office open with some fee-for-service revenue during the emergency. So, we provided telehealth. We provided lists of patients that, number one, had high risk, due to comorbidities or, pulmonary specific issues, as well as a full list, right? So, Travis had mentioned we were worried about the panels going down. So we provided the list to make sure you're touching at least all of your patients at a minimum to educate them that, you're not abandoning them and you're available to them. That was huge. And the fact that the physicians could talk to each other in, Zoom meetings, we had Zoom meetings with literally 400 physicians online. And they were able to share sort of their challenges and, more importantly, share their solutions. And I think that was tremendous. For a doctor to feel enabled to know that other physicians are prevailing in these situations, other physicians were, rising to the occasion. We found that it immediately set the bar much higher, and then collectively the physicians were able to fight the issue. But it was an extraordinary opportunity for ACOs, and I just feel really fortunate to have been able to make a difference with our PCP team. Boy, specialists is another story. We're not seeing a whole lot of access to care issues. I tell you, someone's going to have to do an analysis on how much specialist care is truly needed, because we're seeing tremendous drops in volume, but not a significant amount of complaints. Now, maybe or ER visits or a lot of challenges of lack of specialist access. So we look forward to that coming online, but it just seems like a lot of unnecessary services weren't happening. And of course, we've worked with the hospital CEOs, we've worked with our specialist groups to make sure that there is some services that are being provided, and we've helped them come back online. But again, there's a big learning opportunity for us to truly understand what services were needed, based on what we saw during the emergency.
So just to summarize that, you have seen a significant drop in volume, but people aren't saying, well, I can't wait to get to my specialist. It's just as if those could have been unnecessary. Well, what happens when all elective procedures are available again? Is there going to be an uptick next year? Is that something you're preparing for, where people are the specialists might be trying to make up volume in 2021?
That's what we're expecting. I don't know how much we can manage it. A lot of that has to do with patient choice. I don't know how comfortable patients are going to be coming back to getting elective procedures. There's a lot of tests in other countries about how long you have to wait to get a procedure. There's a lot of tests with other health plans, particularly managed care, on how long you have to wait. So I think patients are going to wait potentially, and we're sort of watching to see if there's going to be an uptick, but I don't see that going to happen.
Travis, what about from your perspective? Have specialists been unnecessarily been utilized in the past, and are they going to go back to that unnecessary level of utilization? How is Aledade thinking through this?
Well, I think I would agree with David, right? We clearly have three buckets now. We have the elective, needs to be done eventually, we can defer so we don't get an infectious disease bucket. We have the, like Gail mentioned, there are some procedures where technically elective would solve a very acute problem. And, as soon as we can find a way to do it safely, we should do it. And then there's the unnecessary, and in the unnecessary bucket might have been larger than we thought. And a lot of it does come into, availability. Like I said, Aledade is a national company. We have some markets where endocrinologists are seeing diabetic patients once every 6 months when the diabetes is completely under control. There's no need. And then we have other, usually rural parts of the country where our PCPs can't get an endocrinology consult to save their lives for a diabetic patient who's rapidly out of control, has multiple problems, and really needs it. So, there's always been somewhat of an axiom in healthcare that, supply drives demand, which is usually not the way it's supposed to work. So I think it'll be interesting to see that as we turn around and as things ramp up and if patients get more comfortable going back into the office, right? Like that well-controlled diabetic shouldn't be going into any office that frequently right now, right? It's just telehealth, their primary care. We're also kind of exploring the idea of, can you do, speaking of telehealth, e-consults with specialists, right? So that edge case where the primary care physician makes the referral back in 2019 would have actually absolutely made the referral because, the patient's retired. I mean, they have the time, they're not 100% sure themselves, just send them to the cardiologist. Well, now that's not as simple anymore. So maybe you can reach out through, say, e-consults, get that opinion, doctor to doctor. And, if we start doing that, kind of like if we start doing telehealth and we start doing that, it becomes part of our workflows. And even when it's perfectly safe to go to a couple of different doctor's offices in the same week, maybe we won't anymore.
Talk about your broader specialist strategy. So Aledade focuses on primary care practices. So how do you figure out who to refer to and manage that and make sure that your docs aren't sending people for unnecessary care? What's your general philosophy around working with specialists?
Yeah, so ours, we really want to be aspirational to be beyond the basics on this one and really move forward. But the basics, the blocking and tackling that have been working for us so far really fall into 3 buckets. One is, all the great data that David talked about, we can see, right? Like you can do. And there are some, you'd be surprised at how many specialists, if you can just get a meeting with them, either doctor to doctor or one of the executive director of the ACO, meeting with them, they're like, of course I'm average on imaging. You're like, well, actually, you're way on the right side, right? Like you're not average, you're 97 percentile. And it's just an awareness. Sometimes they don't have access to the data we do. So sometimes you can just create awareness in their habits. Back in my old days when I was at CMS working on electronic health records and meaningful use, one of our most powerful advocates was a doctor who was prescribing a medication, and he found out he was a top 10 doctor for prescribing this medication by reading about himself in the New York Times. If you had asked him before he read that article, he would have said he was average. So a lot of it is awareness. That's bucket number 1. Bucket number 2 is trying to make them easier, right? Like handoffs, and again, there's a bit of awareness there. Like my EHR does not share data with prescriptions or with other doctors. And I was like, well, when's the last time you actually went and looked in the directory? Oh, I looked at it when they turned it on 2 years ago. Go look again. It's a lot more robust now. And then finally, new referrals. So we have not had, once a patient has a cardiologist, we have, you can scorecard green or whatever, that patient has established that relationship. They would need a big reason to disrupt it. But when you have a patient for whom they're going to go to a cardiologist, they're going to go to an endocrinologist, they're going to go to someone for the first time, that's when we find that, the PCPs really have an opportunity to guide them and really create that kind of a true specialist. I call it a true specialist relationship of like, you have a specialty problem, we're going to send you over there, you're going to get evaluated for that specialty problem, and then you're going to come back to primary care, as opposed to kind of losing you to specialty care forever.
I'm going to shift gears again, and I want to talk a little bit about what we're seeing with the Medicare models. I know all of you have significant experience with what's going on within Medicare. I want to start with you, David. Talk a little bit about what kind of keeps you up at night with what's going on with CMMI and CMS and what's working and what maybe isn't working so well.
So, as Travis pointed out, and I'm very appreciative to Flaco, is very appreciative to Aledade and Millennium, is that, the fact that we've been advocates for the program and making comments to Medicare and how Medicare's listened, the program's really come a long way. And, I've said it before, is we've been dreaming about this enhanced track ACO. It really checks a lot of boxes that we've requested as independent, high-performing PCPs. And, so here we're thankful that we have this great new contract. And then, we've been a little bit distracted of late with CMMI, particularly around, some of the vendor messaging. So, direct contracting is another program, and it's going to be a fit for some organizations, but it's being interpreted as, a handout. It's being interpreted as the PCP can get 100% more revenue with the same or less performance. And I've been just so surprised at the level of misunderstanding. Doctors have come to us saying, hey, I'm thinking about leaving your ACO, which does really well, right? I feel bad for another ACO that doesn't do quite as well as those on this call. And they say, I can make twice as much in this program. And then we read the fine print and they're going to make half. But the fact that the physician is that confused and that misled is really alarming. And, we've commented to CMMI over the years as, their programs are often perceived as the future. And hey, why are you in that antiquated program that's embedded in the law? You should come to this new one. And it's just been a little bit of a challenge educating the physicians that, only 60% of the programs are still around from CMMI, that CMMI can change things. And, they're a good fit for some, but, they're certainly not free money or a handout. But it's just, of late, it's been interesting having to fact check and myth bust based on the information we're hearing from vendors.
Gail, what about your experience? How are you viewing the program and potential other programs?
So we are evaluating whether we want to be a part of the direct contracting. I think we applied for to start next year, and we decided to delay it at least till 22 because of there will be no payments, the first quarter. But to David's point, we're not at all clear. We're actually having an outside firm evaluate, would we be better staying in the enhanced tract or going to direct contracting? Clearly the cap payments is encouraging for everybody for cash flow. But when you start calculating all the withholds and all the potential decreases in terms of quality, and they're focusing on caps, which is something that we really don't, we have less control over that than the actual quality measures. We're really not sure one way or the other which way we're going to go, but it's still under advisement. I think another area that has been concerning is the BPCI program and the overlap of the beneficiaries in each program, and identifying that there is an overlap, and then coordinating, with the in general rule the hospitals has also been a challenge for us. So on the good side, we're very, very grateful that CMS responded so quickly to the telehealth opportunities. I mean, kudos to them for that. But we're just we're still evaluating direct contracting.
I would add briefly on direct contracting, David, because I think, I've been feeling what David Kobanis has been feeling too, a lot of misinformation. And, I'm not going to try and break down the model for you really well, but just to clarify, like what's CMS testing in the model, right? They basically are saying on the total cost of care side, we're going to do it a little differently than enhanced. But they're targeting basically, like if you started 2022 in enhanced or you started 2022 in direct contracting, on the total cost of care, you would basically do the same, right? Direct contracting used as discounts, MSSP keeps 25% of the savings. Do all the math, everything comes back together, and like it looks like they largely succeeded. If you're starting brand new in 2022, they're roughly equivalent on the total cost of care side. But if you're not starting brand new, right? If you started your enhanced contract a few years ago and you're already running 7, 8, 9, 10% savings, then then you're not starting new, and you could have problems on the total cost of care side. But where the misinformation is really coming from a lot is they want to test primary care capitation. It's required over the years to do primary care capitation and direct contracting, and we've seen too much out there from people who are like, yeah, we'll take the primary care cap and we'll just pay you 120% fee for service. And that's not what the model is supposed to be testing. So hopefully over time, CMMI will kind of at least indicate, I don't know if they can actually require, but at least indicate that, like, guys, we want to test capitation too. And that actually happens.
Well, we have covered a lot of information, and this has been very helpful. I'm going to conclude with a final question for each of you. We started the opening question by going alphabetical by first name, so we're going to do alphabetical by last name for this one. So we'll do Travis, David, and then Gail. The question is, you've gone through a lot of effort to get to where you are today, and you've had a lot of really hard learnings. What could you share to others so that they don't have to replicate those hard learnings? And while you're thinking about that, I want to summarize a few of the key points that I took away from this. And I have 3 key points that I think are major takeaways. The first one is to know what the ball is so that you can keep your eye on that. If you don't know what you're really tracking, then you're not going to measure it, and you're not going to be able to get people to change what really, really is relevant. The second is being flexible. So you're keeping your eye on the ball, but there are a lot of different ways that you can go about trying to hit it. And you need to know what matters so that you can be flexible and respond to the realities that change within individual practices, individual markets, or with what's going on in the country at the time. And the third one is that you can prepare a lot, but there are things that you can't prepare for, like a global pandemic, and know what's going to happen. But if you have the leadership, the providers that are aligned and committed to working together, then you're going to be able to collectively figure this out. And I think that's what we've heard from the stories. So for the example of being willing to redeploy case managers to become social workers for a season, people are committed to doing what's right for their patients. And so when you have that working relationship, you can do things that otherwise would be impossible. So with that, we'll go Travis, David, and Gail for hard lessons learned that other people don't need to repeat. And you're muted, Travis.
Thank you. Yeah, so I think the hard question we've learned to ask ourselves is, how are we impacting the daily workflow of someone at the practice who will never, ever, ever go to an ACO meeting? You know, if we is the ACO work becoming so ingrained, and ACO work is basically population health work, and in the practice, that people are doing it without really even knowing they're doing it. And that requires kind of being in the practice. A lot of times we call them practice transformation specialists, coaches, whatever you call them, someone who knows what ACO work looks like, being able to put eyes on in the practice. And then as you mature, finding a way to measure that aspect, finding a way to, you know, whether it's just clearing a work list, whether it is in your app, whether it's an EHR pool and really fancy, but like, you know, the first step is I can now see it with my eyes. ACO work is being done by people who don't even know they're doing it. The second step is I can see that now on a dashboard. And once you can see it on that dashboard, then you can go big, you know, hit those 80, 90, 100% marks.
Thanks, Travis. David.
Sure. So, you know, a huge lesson learned from us is, you know, there's 3 sets of providers that we stratify. You know, you have the PCPs, you know, population health, you know, Medicare Advantage experience in this market. You know, that was a pretty obvious strategic objective, is to help the PCPs perform. Hospitals, facilities, so that would include home health, nursing homes, IRF. Also pretty straightforward is, you know, effectively, if you can manage unnecessary use, you know, change the place of service, keep patients out of that, you know, have PCP managed post-acute. That was also very obvious. And the third one would be subspecialist care. And, you know, we've saved pretty well in the program, but our Part B costs and our specialist costs are 100% higher than the national average. So we kind of just absolutely doubled down on these other sets of providers. And I would certainly argue that was low-hanging fruit, but our subspecialists we've overlooked. And now we're going to start really working with them. And I want to put this in appropriate context, is just like Travis said, is we're going to make sure that they can do better financially, they can do better in patient care by doing the right thing. And we're going to align the incentives so that if maybe they can do appropriate care, maybe they can do a little bit conservative with the same outcomes, then we want to reward them. We want to make sure the specialists know that they can earn more money by doing the right thing through the ACO than potentially by just providing more services. So, you know, that's really the big lesson learned for us, is that we overlooked that, and now we're going to focus on that significantly here in 2020.
Thank you, David. And Gail, final thoughts.
I think what we've learned the most is the more that we can make the hallways easier for the physicians, then that gives them the opportunity to really practice medicine and do the right thing for the patient. I think this value-based world that we have is so administratively heavy for the physicians that oftentimes it distracts them for what we want them to do, and that's to take care of our loved ones and our families. So the more that we can do to take off the administrative burden of the physician, the better off we're all going to be.
Well, Gail, David, and Travis, thank you for your time. This has been very helpful. We've covered some very useful things, and I hope that people find as much value in it as I have. Anybody that is listening, feel free to follow up with any of the panelists, and they'd be happy to connect with any questions that you have. But thank you for joining us today.
Thank you.
Thank you, David.
Bye-bye.
Thank you, everyone.